Can you all turn the video once so that I can take a photo, please? You don't have Dr. Abhishek. Just a quick photo. If you can turn the video on, everyone, before we go live. Vanna ma'am.
Yes, ma'am, we are live now.
Hello and good evening to everyone. On behalf of Team ISPAE, we welcome you all to ISPAE ACES, Academics and Clinical Education Series. This is Series 30. And before we begin, we would invite audience to put all their questions in the Q&A section so that they can be taken up at the end of session. I now please invite Dr. Anurag Bajpai, President of ISPAE, to proceed further. Sir.
Thanks a lot, Dr. Chalak, for inviting me and for providing this opportunity to continue this wonderful program, which has been an initiative for the last couple of years, in which ISPAE has been trying to spread the various aspects of pediatric endocrinology using an interaction between experts from not only the country but across the globe, using case scenarios which are presented, discussed, followed by theoretical discussion. And this session is going to be a very, very interesting, intriguing session where we are going to focus about genetics related to diabetes and how that can change in terms of diagnostics and therapeutic significance. I have immense pleasure in inviting Dr. Siri Atma and Professor Vandana, the two experts for our session, Dr. Hemchand and Dr. Abhishek, the two moderators for the cases, and Dr. Aarti and Dr. Sandeep, the two fellows who will be presenting the cases. It's indeed a great pleasure to invite Dr. Hemchand, who is a very close friend and a person who has been working tirelessly in spreading pediatric endocrinology across the country. He is consultant Department of Pediatric Endocrinology at Mehta Children's Hospital and is also working with a number of publications, including our own ISPAE Journal of Pediatric Endocrinology and Diabetes. He has been very active in terms of teaching as well as research work, and has been involved in a number of programs, has contributed to the Pediatric Endocrinology edition, which I had the fortune to co-author, co-edit with him, and he has got a lot of work on growth and type 1 diabetes. So over to you, Dr. Hemchand, to carry forward the program from there.
Good evening, everybody. Thank you very much. Over the next 30 minutes, we have a very interesting case of monogenic diabetes and what we have learned. I have Dr. Aarti from Gangaram Hospital who will be presenting the case. We will be discussing it in 3 parts: history and physical examination part 1, evaluation part 2, management part 3, and a quick rapid fire. Over to Dr. Aarti for the case presentation.
Thank you, sir. May I share the slides?
Yeah, you can start, sure.
Are the slides visible?
Yes.
Yeah.
Yes.
Okay. So thank you, sir. So good evening to all the teachers and colleagues. So myself, Dr. Aarti, I am doing my pediatric endocrine fellowship at Sir Gangaram Hospital, Delhi. So first of all, I would like to thank ISPAE for giving me this opportunity to present in this platform. I would also like to thank my fellowship mentor, Dr. Archana ma'am, and my mentor for this webinar, Dr. Hemchand sir, for their valuable advice and guidance. So going on to my presentation. So here we present the case of a 7-year, 6-month-old girl who consulted us with concerning symptoms of 1 month duration. Her symptoms were new onset, multiple episodes of bedwetting, increased urination, excessive thirst and appetite, and she also had a significant weight loss of around 3 to 4 kilograms in 1 month. And a random blood sugar check by her mother at home showed an elevated blood glucose value of 342 milligrams per deciliter. This alerted the parents and they consulted us for further evaluation and management. She was not on any medications during the period. So coming to her birth history and development history, she was conceived out of a non-consanguineous marriage and was delivered term through a cesarean section with a birth weight of 3.1 kilograms. She had an uneventful postnatal period with no history of any neonatal hypoglycemia or hyperglycemic episodes. Her milestones were attained normal for age and she was immunized for age. And she did not have any history of any significant illness in the past. Her family history was significant. Her mother was a diagnosed case of type 1 diabetes and she was on insulin therapy. She was diagnosed at 25 years of age. And her paternal grandfather had a history of type 2 diabetes mellitus and father had dyslipidemia. And she also had an elder sibling who was a 10-month-old boy who was healthy otherwise. So as part of the examination, we plotted her anthropometry on the IAP growth charts. So her height and weight both were above the 97th centile for her age. And she had a BMI of 19.9, which was above the 27th adult equivalent, deeming her obese. And on examination, her vitals were stable and systemic examinations were within normal limits. And she had minimal acanthosis nigricans. And pubertal examination, she was in Tanner stage 1. Now, for the confirmation of diabetes was done with a fasting blood sugar of 293 and an HbA1c of 13.3, and urine was tested for ketones, which were negative. Owing to her age and mode of presentation, a provisional diagnosis of type 1 diabetes mellitus not on DKA was made. So as per that, dietary modification was advised and she was started on a basal bolus insulin regimen with regular insulin and injection degludec. And she was advised to follow up with the blood glucose monitoring, diet, insulin charts, and investigations for confirming the etiology of the diabetes.
Thank you, Dr. Aarti. Can you just sum up the history and physical examination, point out the key red flag signs which alerted you?
Yes, sir. So here we have a 7-year, 6-month-old obese girl in a pubertal stage of Tanner stage 1 who presented to us with osmotic symptoms of 1 month duration. And she had a significant family history of type 1 diabetes in her mother and type 2 diabetes in her paternal grandfather. Her systemic examination was unremarkable other than for minimal acanthosis nigricans. And she had an elevated blood glucose and HbA1c.
Very good. That's a non-diabetic ketoacidotic presentation, isn't it?
Yes,
so,
sir. Yes.
Although type 1 diabetes is a possibility, can you list out 2-3 other common differential diagnoses that would come to your mind at this point of time?
So other differential diagnosis includes, sir, since she was obese, we can consider type 2 diabetes. Then because of the strong...
Except for the age, I think that could definitely be considered. Not so early. Okay, very good.
And second is we have to consider monogenic diabetes as well because of her age and family history of diabetes. And
any other rare syndromic form or mitochondrial diabetes, etc.
Mitochondrial diabetes because there's a maternal history of diabetes as well.
Okay, rapid fire. Now that you know that you're looking at probably a non-type 1 diabetes, maybe a monogenic form, what is the significance of maternal diabetes? History of maternal diabetes?
One is, sir, in maternal diabetes, when there is a strong family history, you have to think about inheritable causes of diabetes. And second is, in cases like, again, in monogenic causes of diabetes, you have to think about it. And even in type 1 diabetes, there is around, there is a 1 to 6% chance of, there is a significant family history can be there in type 1 diabetes as well.
Great. And what's the significance of birth weight in monogenic diabetes?
Birth weight in cases like MODY1, HNF4A and HNF1A mutation as well, macrosomic babies have been reported due to the hyperinsulinemia.
Presence of neonatal hypoglycemia, what comes to your mind?
Again, in cases where there is in HNF4A mutation, neonatal, because of the hyperinsulinemia, neonatal hypoglycemia has been reported.
Presence of neonatal hyperglycemia, what comes to your mind?
I would like to think of MODY2, where you have the GCK mutation and it can be a transient neonatal diabetes.
Transient neonatal diabetes. MODY2 will be usually asymptomatic. Transient neonatal diabetes due to methylation defects. Very good. And presence of exocrine symptoms, what comes to your mind?
Exocrine symptoms deficiency is seen in MODY5 and in cell mutation.
Brilliant, brilliant. And this child did not have decay. Any other emergency you could anticipate in this child if it had a monogenic diabetes?
One is, sir, we can think in relation to like type 2 diabetes because there's a residual insulin secretion, whether non-ketotic hyperosmolar coma.
Brilliant. Even monogenic diabetes, neonatal diabetes have been reported with HONC as well. And if this child had anemia, what would come to your mind?
I would think in terms of a renal cause of anemia, where you have MODY5 can present with renal abnormalities, renal cysts.
Time in responsive form of diabetes as well would present with anemia. Okay. And if this child had deafness, what would come to your mind?
Deafness, I would think about a cell.
Wolfram's?
Sorry, sir?
Hard of hearing, Wolfram's? Okay, fine. And if this child had features of rickets, what would come to your mind?
I would again think in the form of renal rickets.
Very good. Certain forms of diabetes, especially MODY3, can be associated with features of rickets as well.
Okay.
Great. Now that you have quickly zeroed into a childhood onset diabetes, maybe a monogenic, how did you evaluate this child? A quick summary.
Okay, sir. Should I go on to the slides as well?
Yes, please.
So the child was followed up with other investigations, and we found that her C-peptide was 2.32 nanograms per ml and GAD65 antibodies were negative. And she was also evaluated for other autoimmune associations like hypothyroidism and celiac disease, which were all negative, and her lipid panel was normal.
Great. Go ahead.
So at this point, the mother had also screened her elder sibling who was asymptomatic, and his FBS was found to be 191 milligrams per deciliter and HbA1c of 10, and he had an HbA1c of 10.5%. So the family history had changed, where now we had 3 members of the same family diagnosed with diabetes. So the mother had started the boy on the same dose of insulin as that of her sister without consulting any doctors. So we went on to examine him as well. So his anthropometry was again plotted, and his height
Go ahead.
97 centile, and weight was just below the 97 centile, and he was also obese. And clinical examination was unremarkable, and he did not have any significant acanthosis nigricans, and pubertal examination was done, and he was in Tanner stage 2. He was also evaluated further. Again, his C-peptide was also normal, 2.78, and GAD65 antibodies were negative, and he was also negative for any other associated autoimmune conditions.
Right. At this point of time, you are zeroing in onto a probable monogenic cause. In your setup, what are the genetic tests that are available? What did you prefer and why?
So that if you feel that you can fit the phenotype of your patient into a specific type of MODY, then you can go for a single genes testing. If you are not sure, you also have multi-gene panels to confirm the diagnosis. And sometimes deletion duplications can also result in MODY phenotype. And in such cases, you can go for a chromosomal microarray. And the most affordable would be a next generation sequencing, which will analyze multiple genes quickly for any MODY pathogenic variants. And later you can do a Sanger sequencing to confirm the variants.
Great. You have given the beautiful cafeteria list that is available, and general tendency is to shift towards more comprehensive genetic testing over targeted gene testing because it's a heterotype of the phenotype. So variable presentation of same diseases or different diseases present in the same way. Great. Go ahead. What did you do? What genetic test did you do, and what did you find out?
Okay, sir. So, sir, I would like to add a slide where we reviewed the maternal history as well in this setting. So we went on to ask the mother how she presented. I've included a brief history about the mother as well. So the mother at the time of consultation, she was 32 years old and she was diagnosed at the age of 25 years. Her presenting symptom was actually pain in the legs. And when we asked about, then she said she had some increased frequency of urination as well, but there was no significant weight loss at the time. And she was evaluated as part of a routine checkup. And then her HbA1c at diagnosis was 0.5%. And due to her age of onset of diabetes, she was diagnosed as type 1 diabetes and was started on insulin Mista twice daily. And around at the time of presentation, she was post 7 years post diagnosis, and her total daily dose of insulin was around 7 to 8 units per day, which was very minimal for a type 1 diabetic. And she maintained a good glycemic control with an HbA1c of 6.9% and occasional lows at that point.
Great. Go ahead. What was
So
the
at this
genetic?
point, we thought of revisiting the etiology of our diagnosis, and we felt that the patients fitted well into the criteria to consider Modi because all of them had an age of onset of diabetes less than 25 years. We had a strong family history, and they were absent or minimal signs of insulin resistance, and all both the children were negative for their autoantibodies, and their C-peptide was normal.
Great.
So we
Great. Very, very nicely summed up. Just a quick rapid fire. Which type of Modi would not have a family history usually? May not have it.
It is reported in Modi 5 and also in Modi 8, sir.
Great. And what autoantibody do you think will give you a lot of weightage?
GAD65.
GAD65 and IA2 as well. Can Modi children have positive autoantibodies? There have been reports of some children having autoantibodies. In fact, IAA antibody is supposed to have a very poor discriminatory role. Very good. And normal C-peptide. Suppose you do a C-peptide assay for a child whom you have labeled as type 1 diabetes. At what level would you consider it as a residual insulin secretion?
If you are considering about type 1 diabetes mellitus, or post an extendable remission phase, like 5 years after diagnosis, if they are having a fasting C-peptide of more than 0.8 and normal random C-peptide of more than 0.6, then we would consider that they have...
Can you include the units as well?
A nanogram per ml, sir.
Very good. Some units report picomoles, nanomoles, etc. Nanograms per ml is what you have written. And I think the timing is very debatable. Some centers resort to testing for endogenous insulin secretion by 2 years. As the later you would do, the more likely you are out of the honeymoon phase. So you build a fit case to go in for a genetic testing. So tell me, how would you counsel the parent for the benefit of a genetic test? What advantage would you think this genetic test performance would be having?
Yes, sir. So the first thing is, when you have a definite diagnosis, the management plans differ. So currently the mother and the girl, both of them are on insulin. So insulin therapy, as we know, is again painful, and the cost of therapy is also different. And second is, when you have a definite diagnosis like Modi, you have to screen the other family members as well.
Yes.
And third is, even Modi is associated with complications, microvascular complication. So an early diagnosis will help in the screening and surveillance of the patients as well.
And there are reports of lesser complications with oral sulfonylurea therapy versus insulin therapy as well, and lower risk of hypoglycemia if you would confirm a diagnosis of Modi 3. Great. So you have built a case and you have convinced the mother. So what test did you do and what did you find?
Yes, sir. So we did a genetic evaluation using a monogenic gene panel, and this test confirmed a mutation in the HNF1A gene in all 3 patients, confirming the diagnosis of Modi 3 in all of them.
Very good. Does the mutation have a bearing on the presentation? There are reports of some children of certain mutation presenting early, exon 1 to 6 versus 8 to 10 presenting early. Some mutations being responders to sulfonylureas, some mutations being non-responders to sulfonylureas, some mutation being associated with Fanconi-like syndrome, etc. These are some of the bearings which this can have in terms of the benefit for the child and the extended family. So what was the technology that you used in this gene panel testing?
We used Sanger sequencing, sir.
You did an NGS based
Next
testing and then you
NGS based
confirmed it by
confirmed with the Sanger
confirmed it by a Sanger sequence. For the just coming back to the LKG ABCD, can you define NGS in one sentence and Sanger in one sentence?
The next generation sequencing is a technique which will screen large numbers of DNA and will help in a quick assessment and to pick out the pathogenic variants. And Sanger sequencing is a definite, will go into the definite mutation and confirm the diagnosis. So every time you do a next generation sequencing and pick up the mutations, you have to confirm it with a single gene.
Very good. If economically feasible, and in this center, MDRF, they do a Sanger confirmation. Suppose this genetic test had been reported as no mutation identified. What would be your next step?
Then we will have to go into a chromosomal microarray because certain variants with deletion duplications have also been reported, which can result in a Modi-like phenotype.
Very good. And how would you screen the relatives of this family?
So if the proband is genetically confirmed, then we have to screen the parents, siblings, and the offsprings of the proband. And if their mutation is confirmed, then you have to go, if they are asymptomatic, you have to go for an early surveillance for Modi. And if the genetic mutation is negative in them, then you can screen them as that of the general population.
Practically, at least a glucose tolerance test will have to be considered, isn't it?
Yes.
Great. And before we go on to the management, regarding this, what is do you know of any non-invasive marker of academic interest to screen for endogenous insulin secretion?
Yes, sir. One has been the urine C-peptide creatinine ratio to differentiate between type 1 diabetes and Modi, where there is a residual insulin secretion.
Right. I think we are all in a country where this monogenic diabetes can be done at such an affordable rate with the help from our public health sector. So we are indeed thankful for that. Do you want to add a note about Modi probability calculator?
Yes, sir. So it's Modi probability calculator is actually based, it is a calculator to which will give the probability to whether to go for a genetic screening test to confirm Modi. So it's based on multiple clinical criteria like the age of onset of disease, whether the child is already on oral hypoglycemic agents or insulin, and how many years have elapsed post diagnosis of Modi. And so based on the probability, if the child is on, if the patient is on insulin treatment, if a probability is more than 10%, then we'll think of Modi. And in a non-insulin treated patient, then more than 20% would suggest to go for a Modi screening genetic.
Great. There are a lot of questions as well. We'll take it. Can you quickly sum up how you manage this child?
Yes, sir.
Not going too much into the details, what drugs you used and how you used them, you can tell it across.
Yes, sir. So once Modi 3 was confirmed, we advised lifestyle modification for all 3 of them. The mother and insulin therapy was stopped for the daughter as well as the mother and the son. And the mother was referred back to the treating physician. So for the children, we started them on oral sulfonylurea. We started with glibenclamide at a low dose of 1.25 milligrams once daily. But as expected, they had hypoglycemic episodes. Low blood sugar, but not clinical hypoglycemic episodes. So then we used a better alternative, which was gliclazide, and it was started at a dose of 30 milligrams once daily for both the children. And this is the CGM graph of all 3 patients, which showed good glycemic control with oral sulfonylurea.
Great. Dr. Aarti, quick questions. You preferred and you chose gliclazides. What is the starting dose of gliclazide?
We will start at a dose of 30 milligram once daily, and you can go up to 120 milligram per day, a total dose of 120.
120 milligram. Literature says higher than that as well, depending on the obesity and the BMI as well. What are the points that would give a favorable response to this to oral hypoglycemic agent therapy in this child?
If the HbA1c level has fallen by fallen or is maintained at a lower level, then that means there is a good response to the sulfonylurea therapy.
Very good. HbA1c is taken as an objective marker. What are the favorable points in this girl which will likely to give you a good response?
when the lows are less, if the hypoglycemic episodes are less.
Early diagnosis, early initiation, lower BMI, isn't it? These are
Yes.
favorable aspects, isn't it?
Okay.
And when would you label this as failure?
So when the HbA1c increases by around 1%, then we say that on sulfonylurea therapy, then we say that that's a failure of the.
What's the youngest age people have used glycoside reported
Uh,
in literature for MODY 3?
I think, sir, 7 years.
Great. And what are the precautions as a physician you would use in this child to avoid hypoglycemia?
One is we can ask the child to take the drug post meals, and proper blood glucose monitoring should be advised.
Yeah, and you would prefer to use extended dose preparations, and
Yes.
you would start these children on a low dose and very slowly escalate.
Okay.
Indication to start insulin?
Insulin is when there is a poor control with sulfonylurea. So then we'll have to think about failure to the drug as well. And then the better option amongst the guidelines is insulin therapy.
Yes, and probably appearance of ketosis is an indication for you to start
During
insulin.
ketones, yes.
And any other second line drugs that have been attempted in MODY 3?
Meglitinides have been attempted, sir. And also articles have been found where they have attempted GLP-1 analogs and GLP-1.
Dose of repaglinide, natiglinide?
Repaglinide is around 0.5 milligram, can be given
For
maximum three times daily, and maximum dose of 4 milligram. Natiglinide, we can go for around 30 milligrams 3 times a day, maximum dose of 60 milligram 3 times a day, maximum of 360 milligrams.
Great. And why is it that the hypoglycemia is lower in this group?
Because it is the pathogenic cause is said to be because meglitinides, they act only on one of the receptors of sulfonylurea. Both of them promote insulin secretion, while sulfonylureas act on both receptors, A and B receptors, but meglitinides act only on one receptor.
And also this HNF alpha has some kind of hepatic alteration leading to a longer half-life of sulfonylureas, prolonged duration of action and extended. So we are almost towards the end of rapid fire before we just go for the take-home messages. How many types of MODY are you aware of?
14 types.
Would you do an early genetic test or a late genetic test?
Early genetic tests.
Advantage of early genetic test?
One is management, tailoring the management, screening, surveillance of members, and also preventing microvascular complications.
Better control, better response, and less likely insulin requirement. Family history is lacking in which MODY?
HNF1 beta.
And which MODY there is no role of OHAs?
MODY 2 and HNF1 beta as well.
Yeah, and MODYs and MODY related to INS and CEL, INS and CEL as well. Which MODY do you get the genetic test frequently negative? MODY 5, because it's more likely associated with large deletions, which is not picked up as point mutations in the NGS based assay. And suppose God decides to give me a MODY, which one would you like him to give to me?
MODY 2, sir.
Thank you so much. Thank you for saying that. Before I think we are on time, I'll just end up with 3 take-home messages from this case. Number 1, as physicians, pediatricians, pediatric endocrinologists, we should break the inertia and use the recommended criteria to perform a proper genetic test and rationalize the management of type 1 diabetes versus MODY. There is a preference of shifting towards comprehensive genetic testing over targeted testing to identify because of the phenotypic overlap, and rational, safe, low dose and stepwise use of oral glycoside is recommended in MODY 3. I think the diabetesgenes.org is a very good website where a lot of guidelines have been given for us to manage these children. I think all those who are attending should take a look into the website and read up when we encounter a case. I think we are finished on time. I think we'll go on with the.
So you can take 1 or 2 questions by Dr. Manda ma'am.
Yeah. So Dr. Aarti, what other tests you would have? GLP-1 receptor liraglutide. When would you prefer to use it?
when there is multiple hypoglycemic episodes reported, and when the child has obesity as well.
Obese, very good.
If they
Associated
have
obesity and probably to prevent the post-prandial excursions, sugar excursions, liraglutide 1.8 milligram. Any additional test you would have wanted to do in this child?
In MODI 3, sir, we have other biochemical markers that are explained, like high sensitivity CRP, which they tend to have a low, and then also renal glucosuria. So
And
this
any
symptom,
other rickets or anything you would like to screen them for? Calcium, phosphorus.
um,
Okay. And what is the C-peptide cutoff for fasting as postprandial?
fasting is 0.8, sir, and the other is 0.6.
Right. Very good. Thank you. I think we can
Yes.
go on to the
Any
lecture.
comment by expert? Comment by expert, Dr. Siri?
Oh, hi. Sorry. Yeah, you actually just mentioned it with the liraglutide. I was just thinking about GLP-1 receptor analogs with the obesity in these cases, and we have seen similar families in the US sometimes where the presentation is a little different like this, and I think it's great that you guys picked up on it despite the obesity, because at least in the US there's I think a real bias with people with obesity where the provider just wants to assume that they must have type 2, even if they were this young potentially. So I'm really glad that you guys picked up on that.
Thank you, Dr. Aarti. It was a very, very wonderful case presentation. Great case, lot of learning points. I hope all the audience had a good learning experience. We'll go over for the lecture by the
Dr. Aarti,
expert.
stop
Yes.
sharing.
Sure, sir. Sure, ma'am.
Ankit, share the introduction.
It's my privilege to introduce Honorable Speaker. Thank you so much, sir, for sparing your time and sharing your knowledge with us. Dr. Greeley. He's an Associate Professor of Pediatrics and Medicine in the University of Chicago. He has been doing a lot of work in this. He completed his undergraduate at Columbia University in New York and PhD in Immunology of Type 1 Diabetes. He's an internationally recognized expert on monogenic diabetes, and he has started this web-based US monogenic diabetes registry, which includes a large cohort of children with suspected monogenic diabetes or known monogenic diabetes. And there are more than 100 publications, and it's great reading and learning from your publications. Thank you so much, sir. Thank you for your time, and we're looking forward to your lecture.
Well, thank you very much for having me. It's certainly an honor. I'll go ahead and try to share my slides here. Can you still see the slides?
Yes, yes.
Okay. One small detail I left out of the bio was, as a teenager, I did spend some time in UP and Punjab. So I just give a Sat Sri Akal to everyone out there. And but then I think I better jump right into my talk, because I'm going to try not to go over. I was actually impressed with your rapid fire questioning just now. I think you managed to cover a very wide breadth of monogenic diabetes. For my talk, I'm going to go into a little bit more detail on some of the main types and how they can present. But we can, of course, at the end, if there are questions, we can try to take some of those. But rather than trying to cover everything, I thought I would focus in on some of the more common forms and how to think about them. Just a quick mention of disclosures, which I have nothing relevant to this talk, just mentioning our funding, and that we do talk about off-label use of different medications, especially sulfonylureas. And I always like to acknowledge the fact that whenever I'm presenting, I'm really presenting on behalf of a very, very large group of people that I am very privileged and honored to work with in Chicago. And this is actually just a a subset of all of the people we've worked with, and I actually haven't even updated it recently. So there's just many people involved, and so let's see. Just to start with a bigger view of diabetes, that I'm sure all of you have some familiarity with this as endocrinologists, pediatric endocrinologists, but just how we think about monogenic diabetes. You might say, well, what's not monogenic diabetes is what we like to call polygenic diabetes, which of course includes our two most common forms of diabetes, that being type 1 diabetes, which, as you all know, is an autoimmune destruction of the beta cells, and then type 2 diabetes, which I mentioned here tends to be obesity or insulin resistance related, but it is important to know that the polygenic risk for type 2 is really based on variation within diabetes or beta cell genes, and so it has much more to do with beta cell function, that the diabetes is revealed in the setting of insulin resistance and the inability of the beta cells to compensate by increasing their insulin production. And as you know, it can be very difficult to distinguish these forms from monogenic forms of diabetes, which can be classified in a few different ways. One of them is to think of them as syndromic or non-syndromic. We tend to make the main classification, as you have done with this session actually, is either neonatal diabetes or MODY diabetes, but understanding that with the different ages and types of presentations, they can sometimes have different syndromic features that might give you a clue as to what the underlying cause might be. And I did appreciate that you made that point, that these days, with the availability of next generation sequencing, it really makes the most sense to do broad genetic testing initially whenever possible, because there really aren't too many of the gene causes that you can be sure of with your diagnosis, but occasionally that'll happen. Of course, the polygenic forms are much more common, but it is important to realize that with the monogenic forms, they can account for, depending on which studies you're looking at, it's somewhere between 1% and 5% of cases that are diagnosed while young. And so pediatric onset cases, the percentage that have an underlying monogenic cause is closer to 5% in at least some countries, some areas, but at least a few percent. And so really, when you think of it that way, the fraction of people with monogenic diabetes is not that far off from type 1, depending a lot on the age of diagnosis, but really thinking about it when you have younger ages of diagnosis, especially. And just to review some of the statistics again, with MODY in particular being much more common than neonatal. And another way to think about it is, even if you don't consider the age of diagnosis, it's probably about 0.4% of all people with diabetes. And so that means there are a lot of people with monogenic diabetes out there. And if in your practice you haven't really been seeing many, it may be that you just haven't done enough genetic testing to reveal that some of your patients may have that. So adolescence and young adulthood are the particular times of onset for MODY, and the majority of causes and the most common causes of MODY have an autosomal dominant pattern of inheritance, as illustrated in the great case that we started with, but can often be misdiagnosed. So that point is that even if the patient comes to you with some label of type 1 or type 2, it's always important for you to think about it yourself as to whether you think they really fit in that category or not. With neonatal diabetes, these are, of course, much more rare, the incidence being around 1 in 100,000 births. will be found to have an underlying cause or will end up with neonatal diabetes, which is typically diagnosed under 6 months of age. But it's important to at least consider the possibility of a monogenic diagnosis in babies who develop diabetes, even up to about a year. I think our consensus guidelines, which should be coming out at some point, are going to land on recommending testing for anyone under 9 months for sure, but to really even consider it up to 12 months or even a little bit later, depending on their other features, such as being antibody negative or having other problems that might suggest a monogenic diagnosis. With the neonatal cases, there can be a family history. Usually the family history involves neonatal diabetes, but sometimes the family history can be adult onset diabetes. But the majority of cases will be de novo, meaning the baby is the first one to have the diabetes. This is just a snapshot of the many different genes. And actually, come to think of it, this isn't even completely updated, but the number of genes that have been associated with monogenic diabetes is now, I think, pretty solidly over 30. And as was mentioned, diabetesgenes.org from the Exeter group is an excellent resource for that. And I just like this picture, just again, this is what I'm going to say over and over again, is that when you have patients who present to you with diabetes and you're kind of thinking type 1, type 2, but there's just something about this patient that doesn't quite fit. It seems like they might not quite be what you usually see. Then, go with that gut instinct and kind of go down systematically, as was demonstrated with the case presentation, really think about whether they might have a monogenic cause, in which case you can get genetic testing. And genetic testing, of course, is the only way to be sure. Again, we'll be kind of harping on these features to be thinking about. There are no features that are absolute with MODY. So every one of the kind of MODY criteria that we talk about, there can be exceptions. But when you have a few of them, that's when really you should be thinking about it. So the key number one thing, of course, is the age of onset. You could say under 30, as I said here. You could think under 35, still pretty possible. Under 25, you should definitely be thinking about it. What's interesting about the case that was presented is being at the age of 7.5 years is actually at the very lowest age where we would even possibly consider a MODY. And that was the other comment I meant to make, was actually, I think you wonder if the obesity in that case actually caused that that kid to present a little bit earlier than we typically see with MODY, where how we usually think about it. And actually the other question I would have asked is if they had puberty, because the onset of puberty and more insulin resistance does seem to be associated with the age of diagnosis for the MODY cases. And one of our kind of ongoing thoughts as part of our monogenic diabetes data commons that we're starting is to look at people who in families where the children have been tested and we know that they have causal or pathogenic variants but don't yet have diabetes, to try to understand better the natural family history and how early you might detect a significant hyperglycemia. But I digress a little bit. So age of diagnosis, family history is absolutely another key. And again, with the case earlier, having that 3-generation family history was highly suggestive. And so if you have a 3-generation family history and an under 30-ish age of onset, and they don't clearly look like type 1 or type 2, you should really be thinking about it. With type 2, as I mentioned, with the case, the obesity can confuse you. But even if they do have obesity, you want to think about, as the case presenter did, the lack of acanthosis or other lipid features that don't necessarily go along with metabolic syndrome. And in the ISPAE guidelines that we have, I think the way we put it was, if you have a 3-generation family history where even if the case in front of you has obesity, but others in the family clearly did not have obesity at diagnosis, and that was one thing I did wonder about the mom of that case, was whether she had obesity or not. That is another clue to really help you decide about testing. But in cases that might look a little like type 1 diabetes, so they might come to you, for example, on insulin. And by the way, the MODI diabetes calculator at Exeter really does put a lot of emphasis on insulin treatment. In the US, though, I'll say that many cases end up on insulin treatment, even if they didn't necessarily require insulin, if that makes sense. So you don't necessarily want to be completely thrown off by that. I'm glad about the emphasis on autoantibody testing, which is really, really helpful. And although there have been, as mentioned, really rare cases where you can have positive antibodies and still have monogenic diabetes, most of the time when you have the positive antibodies, it's going to be type 1 diabetes. All right, so, and GCK MODI is really special, MODI 2, and we'll be talking more about that. So this was a case of a 32-year-old African-American woman with a BMI that wasn't even in the overweight range, who was referred to the endocrinologist for possible atypical diabetes and an interesting family history. She was diagnosed during pregnancy with gestational diabetes, but then postpartum, she was followed and found to have a persistent hemoglobin A1C of 6.9% and an elevated fasting glucose. I meant to clarify, but I noticed you guys are using milligrams per deciliter, and I wasn't aware in India whether you used milligrams per deciliter versus millimolar, but I tried to have both in some of my slides. Anyways, she was started on metformin and was given lifestyle advice, but it wasn't clear how much that was really changing anything. Her family history of diabetes is pretty extensive, and you can see here from the pedigree, this is her, the circle at the bottom, and then has her father and her father's mother, as well as one of her siblings. So highly suggestive. When asked about the family history, a lot of times people don't know much about the other people in the family, but if they did know, they might have said that the fasting blood sugars seem to be especially consistently, persistently elevated in the individuals in this family. And as with this person, the addition of the metformin didn't really seem to make a difference in the A1Cs. And I actually am probably not going to spend time on this, but there's an interesting point to be made about the babies that this patient has had, where one was a little bit large for gestational age and the other was relatively small. And so you can think about what their genotypes might have been. So I'm curious, I hope that some of you are already starting to think of what the genetic diagnosis might be in this case. I did try to emphasize some of the key things being the persistent fasting, mild elevation. So this patient had an A1C of 6.9, so really barely in the diabetes range. And why is it important to make the diagnosis? What's the implication for treatment and future complications? And so, as I hope most of you have guessed, this was in fact GCK MODI or MODI 2. We really are trying to go towards using more the gene names rather than like the MODI 2 designation, but whatever helps you to remember is fine. As long as you recognize that this is really kind of a separate entity when we're thinking about MODI. This has its own very characteristic phenotype that you should really try to keep in mind going forward if you haven't already. So the stable fasting, asymptomatic hyperglycemia. The asymptomatic part is actually really important too. They don't usually present with polyuria, polydipsia, that kind of thing. They're most often will present as an incidental diagnosis. So the blood sugars were tested for some other reason, or they had a screening A1C, or pregnancy is actually a very common time for women to be diagnosed with GCK Modi. So what's the mechanism? It's mutations in the glucokinase gene, where that is really the sensor of glucose in the beta cell that triggers the series of events that lead to insulin secretion. And so as glucose comes into the cell and is converted, is metabolized by the glucokinase, if there's a mutation that makes that process less efficient, it takes more glucose to trigger insulin secretion. So it's just like resetting your sensor for glucose at a slightly higher level. And this is present from birth. So throughout their lives, their A1Cs would be somewhat high, their fasting blood sugar is somewhat high, but it really doesn't progress. It's actually quite common. About 1 in 1,000 people, not just people with diabetes, but people will carry variants that might be pathogenic. And the main point is that treatment is not indicated. I'm going to go through this a little bit quickly because I don't want to run out of time. These are just the many mutations across this pretty large gene that have been described. I said non-progressive. This shows you that the A1C does go up a little bit over age. So at the bottom, this is decades of age going across the x-axis. The people in yellow are controls without pathogenic variants, and the ones with pathogenic variants are in the green. And you can see that people without the variants, there is a slow increase in A1C over time, and people with GCK have that same slow increase, but they're significantly greater at all time points. So in other words, your A1C in a younger person can be from like 5.8 to 6.5-ish, and later in life it might be, 6.1 to 7.5-ish, something like that. It's really important to understand the implications of this diagnosis on diabetes complications are essentially nil. They really don't seem to get diabetes complications. So this degree of hyperglycemia does not seem to have a significant consequence. And the reason that's really important is then there isn't an urgency to treat it. And the other thing that you would find if you try to treat one of these patients is even if you're nervous about whatever their A1C is at 6.9 or 6.8 and you want to treat them, you'll find that the treatment really doesn't even help. And here's a wonderful example of one of the individuals in our registry who was an academic person who wanted to do his own experiment. So he did some time with CGM while he had been on insulin for many years, believe it or not, with a pump. And he tested himself for a while on the pump, and then he took off the pump. And you can see that there's this amazing overlap between the two, where all the insulin that he was taking, all it was probably doing was suppressing his own insulin secretion a little bit, but it really wasn't helping his blood sugars at all. And I think I'm going to skip over this, but just to say it's often not recognized and it's not treated correctly. And when you have one case, you have a whole family. So it's really important to get that genetic diagnosis so you can help others in the family as well. So second case is slightly older, but he had been diagnosed some time ago, but he's presenting to your clinic, 46 years old. He's slightly overweight. His insulin dose is pretty good, but not quite at what we would consider like a replacement dose of insulin. His A1C is pretty good, but not great. He does have a little retinopathy. He mentions that several of his relatives have type 1 diabetes, and that with 3 of his sister's children having been diagnosed recently, he was kind of wondering more about like, how could it be that he just has type 1? Like, does it really happen that much in families the way it seems to be happening in his case? When he was diagnosed, he was 17. He did have symptoms of polyuria polydipsia. His A1C was pretty elevated at 9.6, but antibodies were negative, and he's been on insulin ever since. So I won't belabor the point. This actually has some similarities with the original case. You have that significant family history of the young age of onset, the insulin dose not that high. I didn't emphasize it, but not really ketones, no DKA, and the antibodies were negative. And so this is where you really want to consider genetic testing. And it turns out this family has a well-known pathogenic variant in HNF1 alpha, similar to the first case. And there was a 3-generation family history. The antibodies were negative, no DKA. The C-peptide, readily detectable. That the important point there, as was discussed, if it's been a few years since diagnosis, your type 1 patients, the C-peptide might still be detectable, but you'd expect it to be really low. Whereas in these 1 alpha, 4 alpha cases, the C-peptide should still be pretty robust. It's very difficult to use the C-peptide to distinguish with type 2, but it definitely helps with type 1. Just to say that the mutations has an effect on the SGLT channels in the kidney, and so you get glucosuria more in these cases, and that actually suggests that using an SGLT inhibitor may not be the best choice in these cases where they already have low SGLT activity. These are the mutations all over the gene again. So adolescence and onset in adolescence, young adulthood, family history is important, ketosis is rare, antibodies negative. I'm saying all the same things over and over again, but that's just really to emphasize. Oh, just this is like my little break slide to take a sip of coffee. This is my family out at a dude ranch in Colorado during the pandemic. All right, so one more case is a 22-year-old man who's coming to see an adult endocrinologist. You know, I will say, I just want to make a quick comment. My brother is an adult endocrinologist, but I think it's pretty clear that pediatric endocrinologists think more deeply about their cases and about genetic possibilities. So even though this case seems like the pediatric provider may not have picked up on the diagnosis, it's usually the other way around, and the pediatric endocrinologists are making the diagnoses more than the adult endocrinologists. Anyway, so when presenting to the adult endocrinologist, it turns out his diabetes was diagnosed around 15. I did the millimolar here, but his blood sugars went pretty high, 300s, 400s, but he didn't have DKA. He is not really overweight. He's on a decent dose of insulin, but not like super high, not super low. His A1C, his control isn't that great, but it's pretty good. And again, antibody testing negative, C-peptide readily detectable. Now, so far, you know, he's a little bit on the fence, but yeah, you're thinking maybe, but interestingly, he doesn't have a family history in this case. But what he does mention when you ask about family history, he says, oh yeah, you know, my mom actually mentioned to me that when I was a baby, like I had high blood sugars, and I think maybe they had to treat it, and then it kind of went away. I don't know exactly. I can call her and ask her if you want me to. But my point here is, of course, I'm trying to set this up for Dr. Vandana, but if you have any kind of history of high blood sugars as a baby, that's really important. By the way, as they mentioned in the case, if you have a history of low blood sugars in the baby, or high birth weights, or in this case, a low birth weight, all of those things are really important clues that you might want to consider genetic testing. In this particular case, it happens that this individual has 6q24 related transient neonatal diabetes. And we did a study of a few cases showing that that they actually respond quite well to sulfonylureas because they really do have a pretty well preserved beta cell insulin secretion capacity that can be pushed a little bit with sulfonylureas. So I won't say much more about that. And I don't really have time because I know I'm already, I think, almost out of time. But to mention about our registry and the genesis of that now, not quite 20 years ago, about 15 years ago, we got a lot of publicity, had a lot of people reaching out to us. One of our families made this wonderful documentary called Journey to a Miracle about the discovery of some of the mutations and the work with our team in Exeter. and does a great job literally showing how these families are dealing with monogenic diabetes. The XR group has a podcast series that you can check out. And our registry has been a wonderful way of trying to grow our understanding of the individuals with these rare causes of diabetes. And you can see this slide is a few years out of date, but we continue to grow the registry with many different cases with many different underlying gene causes. And we are very happy to receive inquiries, questions, any kind of help if you need it. We try to do the best we can to provide that. We encourage genetic testing, which in the US is cost effective. And what was I? So genetic testing results, it's really important that the variants are whether they're known or not to be truly pathogenic or not. And if your testing report says VUS or variant of uncertain significance, just keep in mind that it could very much just be a benign variant and the testing lab didn't have all the information, or it could be pathogenic. And if you have in particular those kinds of cases where you've done the genetic testing and you're not sure whether the variant is truly causal or not, those are the kind of cases we really can try to help you with. And just to finish that, in certain of the forms of MODY in particular, making the diagnosis is really going to make a big difference in the treatment and their outcome. So it's really important when you have cases in front of you to really question the diagnosis. Think about it yourself. What are the clues? What are the details? Does it deserve consideration of genetic testing? And if your gut is telling you they're not quite type 1 or type 2, I really encourage you to do that. This is our registry website, and this is a picture of one of our family meetings we had a few years ago. And I think I am out of time. I hope I didn't go too far over. But I'm happy to take some questions if we have time for that.
Pinchan sir, any questions?
I didn't. I mean, I can talk about some other things if there aren't any questions, but I didn't have time to mention some work we did as part of the Precision Medicine Diabetes Initiative. There's some good systematic reviews now available about treatment, and we're finishing one about prognostics. One interesting tidbit is that with 1-alpha, 4-alpha, they actually have a significant risk of cardiovascular disease that we don't understand very well. That we need, we need to learn more and like what is the best treatment of those cases, and that's actually where GLP-1 receptor analogs, there might be more of a rationale to try to lower that risk, especially as they get older if they have obesity. And we also have started there's been a new study ongoing for a little while in the US called Radiant, where we're taking atypical cases that look something like type 2 but are very atypical and don't have known causes of monogenic diabetes. We've now enrolled, I think, somewhere around 1,000, where we're looking at their genetics and doing a deeper dive to see if we might actually find new gene causes. But yeah, if there aren't any questions, that's fine with me. If things come up later with the cases, though, I'm happy to chime in if you'd like.
Yes, Anurag sir.
Thanks a lot for a wonderful overview of this scenario. I know 30 minutes is very small for this sort of extensive talk, and we are really honored with your presence and the overview that was provided. We will now be moving forward to the second part of this session, which will be on the other aspect, the other age spectrum of neonatal diabetes. And It's a pleasure to invite close friend and colleague Dr. Abhishek Kulkarni, who has been working extensively in the field of pediatric endocrinology in across the country, and he has been a senior consultant pediatric endocrinologist at SRCC Mumbai and HN Reliance Foundation. He has been working extensively across different aspects of pediatric endocrinology, particularly with emphasis on genetics, particularly for monogenic diabetes, neonatal diabetes, genetic obesity syndromes, and has numerous publications and presentations across the forum. So welcome, Dr. Abhishek, and over to you to start off this session and moderate the session.
Thank you, sir. Thank you very much for having me here today evening. I'll now invite Lieutenant Colonel Dr. Sandeep, postdoctoral fellow at Regency Kanpur, to present his case on his case today. Dr. Sandeep.
Yeah, good evening, sir.
Over to you.
Thank you very much, sir.
Yeah,
thank you very much, sir.
We'll begin with the presentation, and wherever there are interjections of interest for learning, I shall be making them. And but I'd like you to present your case with good flow. Please go ahead, Sandeep.
Thank you very much, sir.
Thank you.
Sir, may I have the permission to share my screen, sir?
Yes, please share.
Is the screen visible?
Yes, Sandeep, it's visible.
I'm Dr. Sandeep D. Paimode. I'm presently working as a fellow in the Department of Pediatric Endocrinology at Regency Hospital, Kanpur. First of all, I would like to thank ISPAE for providing me this opportunity to present this case. I would also like to thank Dr. Abhishek Kulkarni, sir, who is mentor in this case. I would like to thank Dr. Anurag Bajpayee, sir, who is my mentor at Regency Hospital. This case is a case of infant with diabetes who was subsequently found to have ABCC8 gene mutation and subsequently was not responsive to sulfonylurea. The patient is an 8-month-old female. She presented to the emergency department with DKA. She was first product of non-consanguineous marriage. At presentation, the sugar at emergency department was 540 milligrams per deciliter. She had metabolic acidosis and also ketosis. This fulfills the criteria of DKA. In the history of presenting illness, she had polydipsia, polyuria since last 2 weeks, and which was associated with weight loss of around 2 kgs. Also, she had fever and mild URT-like features since 3 days before admission. Gradually, she became lethargic and became drowsy in the span of next 2 days. And at the time of admission, she had a rapid breathing. In the negative history, there were no history of any malformations, cardiac, renal, or hepatic involvement. No history of any developmental delay, hypotonia, or seizures. No history of diabetes in the parents. And no history of similar illness, renal, hepatic illness in the family. In the birth history, there was no history of diabetes in the mother. Antenatal history was uneventful. She was born by full-term normal vaginal delivery, cried at birth. Birth weight was 3 kg, and there was no evidence of any IUGR. She was exclusively breastfed for 6 months and subsequently started on complementary feed. At the time of diagnosis, she was able to sit with support. She was started just crawling. She had pincer grasp, and developmentally, she was normal in all domains. She was the index case, and there was no history of any diabetes in the family or any similar illness in the family. In the examination, at presentation, the patient was drowsy. The GCs was 13/17, E4, V4, M5. Her pulse was 142, which was regular, normal volume character. There was no radial femoral delay. She was tachypneic with Kuznets breathing. The respiratory rate was 52 per minute. BP, the systolic was 80, 88, and diastolic 50 millimeters of mercury, which was between 58 to 98 centile for age and height. sp2 in the right arm in room air was 98%, and she was afebrile. In the anthropometry, the length was 70 centimeters, which was plus 0.53 SDS. Weight was 6.4 kg, which was minus 1.71 SDS. Head circumference of 42 centimeters, which was between 10 to 25 centile. And the upper segment, lower segment ratio was 1.6:1. She was prepubertal. In the head-to-toe examination, there was no dysmorphism. She had features of dehydration in the form of dryness of tongue, sunken eyes, and dryness of eyes. In the systemic examination in the respiratory system, she had Kussmaul's breathing, air entry was equal bilaterally, no added sounds were heard. In CNS, G6 was 13/50. She had normal size, normal reaction to light in pupils. There was no anisocoria. Deep tendon reflexes were present, and power and tone could not be assessed. Rest of the systemic examination was normal. The further investigation, the CBC count was within normal limit. SGPT was 14.7, creatinine 0.4 milligram per deciliter, calcium was normal, CRP was negative, random sugar at lab was 580 milligram per deciliter, sodium of 144, and potassium of 4.1 millimole per liter. In the blood gas, she had metabolic acidosis with pH of 7.12, bicarbonate of 8 millimole per liter, PCO2 22 milligram per mercury, and she had a high anion gap. Ketones were positive with a value of 4.8 millimole per liter. So a diagnosis of moderate DKA was made, and the likely etiology was either autoimmune diabetes mellitus presenting in infancy or delayed presentation of neonatal diabetes.
Sandeep, so that's that's nicely presented. Now, learning for all of us here is this is slightly atypical manifestation, if at all one has to consider the diagnosis of neonatal diabetes. By definition, it is typically most often within the first 6 months and rarely between the 6th and 12th month. But anthropometry of your infant, very well grown or relatively well grown, whereas most cases with neonatal diabetes, both on the length and the weight would hover around the 5th centile, or somewhere between the 3rd and 25th centile. Strangely, no antenatal history of intrauterine growth retardation. Again, in neonatal diabetes, just to emphasize the role of insulin in utero, no antenatal IUGR in your presentation. And neurologically, developmentally normal. Again, if you're looking at potassium channel mutations, some form of neurologic or developmental involvement, I mean, up to 1/4 or 1/3 of the cases in our part of the world. And as they grow older and we perform neuropsychometric analysis, a large section of them will have some form of domain deviation and no developmental defects or organ malformations or extra pancreatic features. Now, if you look back at definitions or criteria for screening patients in infancy for genetic or monogenic diabetes, quite a lot of them do mention the need or the presence of extra pancreatic features before moving towards a next generation sequencing or exome analysis. So I just wanted to highlight the atypical presentation, these 5 aspects which do not favor clinically the diagnosis of neonatal, late presentation of neonatal diabetes. So good, you've had autoimmune diabetes presenting in later part of infancy as your differential diagnosis. Now, please proceed further. Let the audience know how you evaluated this infant.
Thank you, sir.
Sandeep, please go ahead with your
Slides are not moving, sir.
Oh, okay.
Click on the click and then try moving.
Yeah.
I think you can reshare the screen.
Yes, sir. So, since the patient presented with DK, she was managed as per the present guidelines, ISPAE 2022 guidelines, with IV fluid, insulin infusion, potassium, and other supportive care. She gradually improved with the return to normal sensorium. There was a resolution of dehydration and resolution of DK. After the initial management of DK, patient was shifted to ward, and she was then transitioned to basal bolus insulin with multiple daily injections. Initially, a basal insulin in the form of degludec was started at the dose of 0.2 units per kg per day, and prandial dose was based on the volume of breast milk and pre-fed sugars. And for this patient, we use the dose of 0.1 unit per kg per day of a rapid-acting insulin 4 times a day. Initially, the sugar was monitored 8 times a day, and subsequently, gradually, with a better glycemic control, it was reduced to 4 times a day. Gradually, she attained a good glycemic control. Since it was an early onset diabetes at the age of 8 months, a beta cell autoimmunity panel was sent and which was subsequently found to be negative. And we subsequently got her genetic test done, which was suggestive of a variant of unknown significance in ABCC8 gene causing neonatal diabetes. This was the genetic report. And since genetic report was suggestive of ABCC8 gene mutation, she was transitioned to oral sulfonylurea gradually. She was started with oral glibenclamide at a dose of 0.1 mg per kg twice daily. Gradually, the dose was escalated. However, the sugar remained high. Glibenclamide was discontinued due to persistent hyperglycemia and low C-peptide levels of 0.1 nanogram per milliliter even after treatment. And then she was transitioned to again basal bolus regime with which she is having a good glycemic control.
So, Sandeep, here, if you could go back to your genetic test results, what is of interest is, I mean, if the presentation is beyond 6 months of life, you would have to have a negative islet autoimmune panel before you prescribe the genetic test, unless there are very stark features like an unusual family history, if there's presence of extra pancreatic features or congenital defects, or multiple autoimmune disorders where we are looking at widespread autoimmune presentation very early in infancy. So you rightly did the autoantibody panel, found it to be negative, and then looked at the exome analysis. Also, the variant here is of uncertain significance. It is not a known pathogenic mutation. However, I do see that in your SIFT analysis, it has been predicted to be damaging, but it has not been reported previously in any of the known databases. And one important point for learning of all of us is most of these, good 80-85% of these are de novo. So they are the parental segregation is not likely to add value except in the recessive forms or the homozygous forms. Most of the dominant ones are de novo and are occur during gametogenesis or immediately post-zygotic. So they're not, the parental segregation is not likely to help. And another atypical feature here is 80 to 90% of the patients with KCNG11 or ABCC8 mutations are responsive to sulfonylurea in variable extents, either completely or partially. Whereas I see that in your patient, there has been no response even at an unusual dose of 2.3 milligram per kg per day. So this is a very atypical presentation, making us think that are we dealing with infantile presentation of autoimmunity, or is it actually a new variant that has been isolated, which is sulfonylurea unresponsive. Please proceed with your presentation.
So, learning points of these presentations, the incidence of permanent neonatal diabetes is less than 1 per 90,000 live births. Potassium channel defects are the most common cause of permanent neonatal diabetes. We should always consider neonatal diabetes if the onset is before 6 months of age, and if between 9 to 12 months, if the autoimmunity panel is negative. Genetic testing is very important because it has implication in the treatment as well as in the prognosis. Around 90% patients with activating mutations in potassium channel defects, they can be switched to sulfonylurea with a good response. However, 10% patient remains unresponsive. Sulfonylurea treatment in the potassium ATP channel defect neonatal diabetes drastically improves the glycemic control as well as some of the features in neurological cases. The typical dose of glibenclamide is usually 0.5, and in some cases, the higher dose is required up to 2.3 milligram per kg per day. Sulfonylurea non-responsive cases are treated with the standard insulin therapy. That's all from my side, sir.
Yeah, Sandeep, also when the presentation is within the first 6 months of life, it is important for us clinicians to not miss out on methylation specific MLPA for 6q24 locus related conditions. They are the commonest cause of transient neonatal diabetes. Also, there are variants in KCNJ, ABCC8 well reported, some which even we have reported, which have a transient course. And we need to understand that a large number of these, more than 85% of these, are likely to relapse back during puberty. And they are amenable to sulfonylurea treatment then. There is also a role of initiation of sulfonylurea treatment even prior to the turnaround time of the genetic test reports. It often happens that you have a presentation, you have a new infantile presentation in the first 6 months, and you do not see any other malformations or extra pancreatic features or syndromic features, and you're tempted to offer a sulfonylurea trial even before the turnaround of the genetic test results. So it's perfectly justified to do that. However, in patients with extra pancreatic features or genetic malformations or syndromic manifestations, it's unlikely, I mean, for them to be KCNJ or ABCC8 mutations. There are different group of diabetes. And what we need to understand here is two major groups is one, those associated with malformations of the pancreas leading to altered beta cell development or beta cell survival. And second is abnormal functioning of the existing beta cell, which is due to mutations in the KCNJ, ABCC8, or then 6q24 locus, where the beta cell function is altered. So the KCNJ, ABCC8 group, as you rightly pointed, are amenable to sulfonylurea in up to 90% cases, in variable extent though. And a trial of sulfonylurea is very well merited, even prior to the advent of genetic test results. So in presentations less than 6 months of age, it in next generation sequencing and also methylation specific MLPA to look for transient neonatal DM. And greater than 6 months of age, you must have a negative auto antibody panel before you consider the next generation sequencing, except in those with malformations or other congenital development defects or syndromic forms where we are likely to look for monogenic forms of diabetes. So we now invite questions from the audience, if any, and comments from other panelists and experts.
Dr. Siri, he had some comment.
Sure.
Yes, sir.
Yeah, I was just going to clarify that the testing the parents can still be helpful in situations like this, because if one of them does carry it and definitively does not have hyperglycemia, and especially if they're a little bit older, that could help give evidence that the variant may in fact be benign.
Benign, yes.
But I think other things that you said, I exactly agree with. Like, you could still do the antibody testing. We don't have great data, but there's some suggestion that cases that are that young, the antibody testing might not be as reliable, but it could still be type 1. And the Exeter group did publish a series there where the use of the T1D genetic risk score, the polygenic risk score, can also be helpful. That test is not definitive, like yes or no for sure, but it just gives more evidence. And that isn't really available clinically yet, although there is kind of a consideration going forward where we might start to use those kind of polygenic testing clinically in the future. But it's a little tricky because clinicians want something that says yes or no, and those tests are not quite like that.
Yeah, so very, very valid point brought up by Dr. Siri is presence of the variant in the parent without hyperglycemia is very likely to let us know that it's a benign and a non-contributory variant. So Sandeep, that's, I like we were discussing when you were discussing the case with me, parental segregation may not have a positive predictive value here, but may help us rule out if we identify the same variant in the parent, saying that it's a non-contributory one, if the parents do not have any existing hyperglycemia.
And, we do have the monogenic diabetes expert panel through ClinGen, the US NIH effort to curate genes that are associated with conditions in a formal way. And then also we curate each and every variant of the genes to try to help this classification. So once somebody knows of a variant, we want to kind of gather the information systematically for everyone to make use of. So it may be worth like sending us this variant so we can share it with the group, like with whatever information we have. And you can actually deposit it in ClinGen, or if someone wants to email it to me, we could email it to our group. I think Radha Venkatesan from Dr. Mohan's group, I think is part of our MDEP group. But if there's any other genetic testing labs in India who want to join the group, that's another option, by the way. You can reach out to me.
Any comments from Vandana ma'am?
No, very interesting case presentation, and I agree that this case probably it might have been just a VUS, and maybe the infant actually had type 1 diabetes only, because I think in our clinical practice, whenever we see infants presenting older than 6 months, actually very few turn out to have, and specifically ABCC8 and KCNJ11, I think those are not the genes associated with neonatal diabetes that would typically be associated with a later presentation. So probably this one was just a variant, but yes, definitely what Dr. Grilly has suggested merits further investigation and further workup for this particular child.
Yeah, I agree with that point that insulin gene mutations are the ones more commonly a little bit later. Very rarely there have been KCNJ or ABCC8. But I did want to, by the way, I meant to say, like, I really was impressed that you guys went up to the high dose of sulfonylurea when testing the responsiveness, because by getting up to that dose, and there was clearly no C-peptide production, you made it much more definitive that it's not a sulfonylurea responsive variant. And in that case, it's less important anyway, even if it somehow is related, which is doubtful. It's not changing the treatment. And you made that case definitively. We've had other cases where people do it in a confusing way and you don't have a definitive answer, but you did a great job with that. And the last point is DKA in neonatal diabetes is common. We did a series, it was like 2/3 of the cases will present in DKA. So unlike MODY, where DKA makes you think it's not monogenic, in this case, the DKA shouldn't steer you away from monogenic cause. So I think it was very reasonable to do genetic testing here for sure. Yeah, so great case.
Yeah, so this was a very challenging case from our side, because we definitely discussed after all autoimmune workup and we thought we'll go for genetics, and the genetics was ambiguous, but the parents were wanting to take the chance of going to our oral agent. So we did try hard, as Sandeep said, going up to a very high dose. But then finally now we have nearly reconciled to the fact that they will need lifelong insulin from that perspective. We'll definitely love to have inputs from the group with regards to this variant in particular, as well as possibly like to do in the parents, although parents' glucose status is absolutely normal. So we will do further workup in that perspective as well.
Yeah, another important point which Dr. Siri brought up is the usual threshold doses of sulfonylurea. In these cases, you start with 0.2 milligram per kg and go up to 1 milligram per kg. But when you want to make a diagnosis of sulfonylurea responsive versus unresponsive, doses up to 2.8 milligram per kg may have to be used. And that's a very good thing that was done in this case.
We have found in some cases that the initial requirements are very high and then they tend to taper out after some time. That's what our experience has been. So,
and I was going to say, especially when you have the parents who are really like hoping for this switch to an oral agent, by going up to that high dose, you've really made it definitive so that they can put that hope to rest, which can sometimes difficult to move on, but you've made it very clear. So I think that was a good idea.
Dr. Siri, any take on the suspension of sulfonylurea? Because we generally use pulverized preparations of glibenclamide in practice. Some of our patients with deep pockets do import the amglidia, the suspension of sulfonylurea. Your experience of its use? We have used it in some.
You know, it's actually the commercial form is still not available in the US because they've been there's been a suggestion they might be trying to get FDA approval, but they haven't until now. And so with the babies, making the suspension is really not too difficult. And so we usually recommend that.
Yeah.
And even though there isn't great data on stability, it really does seem to work really well in this very stable. We have them usually get new every 2 weeks, which is probably pretty conservative. It probably lasts longer than that. And as they get older, though, we try to transition to the pills just to be more sure about doses and things. But the older patients taking up to 8 to 10 pills, like 2 to 3 times a day, is kind of a lot. And so we actually, there's a consideration of using the concentrated version of the commercial product. Could actually be easier for those patients.
So generally across India, I believe, I mean, Professor Jain will obviously enlighten us, but most of us use tablets which are pulverized and suspensions made freshly just before dosing the patient. But for a small number of patients, we have procured from France the suspension, the commercially available. I mean, it's very, very sparingly available. And for the interest of the audience, we worked on it for 2 patients recently. There are 2 strengths, one having 0.6 milligram per ml and the other a very concentrated one with 6 milligrams per ml. And while you're dosing it, the one thing you need to keep into account, which the manufacturer and my colleagues from the French group taught me, is you need to make sure you're not giving too much of sodium benzoate, which is there in the preparation, to the infant. So your dose, the volume of the suspension that you're giving to the baby must be checked when you start escalating the doses. But I think for practical purposes, we could limit ourselves to the pulverized form of glibenclamide that is easily available across the country. So thank you, Dr. Siri. And
We have one question in chat box if you want to take before we start.
yeah, please. Let me see what the question. Yes, I mean, Dr. Anju ma'am's asked, don't we want to start the baby on CGM? Dr. Anurag, any reason why you did not consider? And also, why wasn't insulin pump therapy considered, at least initially? Because it's much easier to deliver smaller doses.
Yeah, definitely. So this is obviously the ideal scenario. We have been using intermittent CGMs in the child, but the affordability issues also we have to consider. So they were not affordable for that perspective.
Okay. Can we move ahead, Zala?
Yes, sir. Yes.
It's my great pleasure to introduce Professor Vandana Jain, a very accomplished clinician and academician, Professor, Division of Pediatric Endocrinology, Department of Pediatrics, All India Institute of Medical Sciences, Delhi, and coordinator and director of the DM Pediatric Endocrinology program at AIIMS, Delhi. She has more than 135 peer-reviewed publications, has been the principal investigator for more than 20 funded research projects, has been the editor of the case-based reviews textbook in pediatric endocrinology, and her areas of interest are metabolic syndrome, effect of infantile growth on later cardiometabolic outcomes, innovations in diabetes care, and disorders of sex development. Pleasure having you here, Professor Vandana. Over to you for your talk.
Thank you, Dr. Abhishek. So I'll share my screen. Can you just stop sharing? Yeah. I hope my screen is visible.
Yes.
Yeah. So very good evening, everybody. And after that very interesting case and very nicely moderated by Dr. Abhishek and very good presentation by Dr. Sandeep. So I'll again take a case-based approach to neonatal diabetes mellitus, where we'll try to see a wide spectrum of cases. So let's begin with the case. A 1.5-month-old boy presented to us with polyuria, lethargy, and respiratory distress for 1 week. On evaluation, he was found to have moderate DKA. So as highlighted by the previous speaker, as well as Dr. Greeley, so DKA is a relatively common presentation in babies who present in this age group. And this baby was second born to a 3rd-degree consanguineous couple. Now, consanguinity is important, and we will later on see in this presentation how. the baby had low birth weight of 2.2 kilos. Also, there was a sibling who was diagnosed with diabetes at 1.5 months, but this baby had died at 3 months due to sepsis. Although he was admitted at another medical college hospital, but unfortunately, parents did not have any reports because they had taken the baby Lama after about 2 weeks of treatment there with insulin, and the baby later died at home. So this particular baby, when he came to us at 1.5 months, weight was 4 kgs, which was actually good. There was no dysmorphism. Systemic examination was normal. Ultrasound abdomen, LFT, and thyroid function tests were done, which were normal. So now, basically, what is important here is what is the diagnosis? Is it neonatal diabetes? If so, whether it is permanent or transient, what is the etiology? How do we manage? What is the prognosis? And what is the risk in subsequent offspring? So what is neonatal diabetes? Almost all cases of diabetes presenting before 6 months of age, and a proportion of those between 6 to 12 months are of monogenic etiology. The incidence is 1 in 90 to 1 in 160,000 live births. Some key milestones in the history of neonatal diabetes. Actually, it was first described just about 30 years ago in 1995. And the first mutation to be identified, which was a positive for permanent neonatal diabetes, was in PDX1 gene, which we know leads to pancreatic agenesis and therefore exocrine as well as endocrine pancreatic insufficiency. And KCNJ11 and ABCC8 gene mutations, which are of course very important because these mean that the baby will be responsive to sulfonylureas in most cases. They were identified just about 20 years back. And now, of course, in the last 2 decades, there has been immense progress, and now more than 40 different genes that regulate the development or function of pancreas or insulin action have been identified. So, in fact, just as Dr. Greeley was mentioning, when he first identified monogenic diabetes as the cause in one of his 15-year-old patients, similarly, we actually first described one case in a baby, and that baby was born in 2009, and we diagnosed him, and then we actually published it. So it was like, we also presented it at multiple fora because it was like, wow, so this baby was, responsive to glibenclamide because this was an ABCC8 mutation. And so like a lifelong insulin, instead of lifelong insulin, the baby could be managed very well on oral sulfonylurea. So it generated a lot of interest at that time. And of course, Exeter Lab was a partner in the diagnosis of this baby. So coming to pathogenesis, so these genetic defects, the monogenic defects in neonatal diabetes, they act via 3 particular mechanisms. One is abnormal development of the pancreas. So for example, PDX1 defect and PTF1A mutation, which is again a transcription factor, which is involved in pancreatic development and cerebellar neurogenesis. So the affected patient would also have ataxia. Then decreased beta cell mass, secondary to increased apoptosis or destruction. So here the classical example is the INS gene, and specifically the heterozygous form. So as we will actually allude to later also, we know insulin gene can present as heterozygous and homozygous forms. And contrary to, what we would think in terms of common sense, actually heterozygous variants of insulin gene are actually associated with permanent form of neonatal diabetes, whereas homozygous forms are often associated with transient form. So insulin heterozygous, because this leads to synthesis of misfolded proinsulin that is retained in the endoplasmic reticulum and resulting in apoptosis of the beta cells. Then beta cell dysfunction that limits insulin secretion. Here we have the potassium channel gene mutations, KCNJ11 and ABCC8. Also GCK, as we saw in the MODI presentation as well, how GCK is involved in the regulation of insulin secretion. And the homozygous insulin gene mutation, because here actually the insulin production is less. Typically the defect is in the promoter region of the insulin gene and the production is less. And then we have the defect in IF2AK3 gene. This is an interesting gene and I'll talk about it a little later with a case. So coming to etiological profile, this is of course an older slide from 2015, Lancet publication by Exeter Group. So the important message from this slide is that basically genetic mutations are found in about 80% of children with neonatal diabetes. And in non-consanguineous cohorts, KCNJ11 and ABCC8, they are responsible for up to 45% of all cases. Because, as Dr. Abhishek also mentioned earlier, these are heterozygous mutations, so autosomal dominant. So family history is actually not important here. Whereas in consanguineous cohorts, the most important mutation is IF2AK3, and the others, like the potassium channel mutations, are much less common, just accounting for about 12%. So this has implication to Indian population, where we know that consanguinity rates are typically higher than what we see in the West. So also, you can see here, GCK mutation is another common one here. Insulin, which is probably homozygous, may also be more common in the consanguineous cohorts. So I'm not going into too much of detail about the pathophysiology of each mutation, but the commonest, we should actually, just for a quick revision for the students who are attending. So let's begin from here. This shows the pancreatic beta cell, this particular cartoon, and how the potassium channel works. So this potassium channel it's an ATP sensitive channel, and the way to remember is that it is normally a leaky channel. So it's functional, it's open all the time, and potassium is being excreted out of the cell. Potassium is being thrown out of the cell through this channel all the time. But when there is metabolism of glucose, when there is glucose which is entering inside the cell, glucokinase is important here for the metabolism. When ATP is generated, so it is ATP sensitive, and increase in ATP leads to closure of the channel. Closure of the channel leads to depolarization of the cell, leading to calcium influx and insulin exocytosis. So what would happen in mutations in this channel? So what kind of mutations we are expecting? Activating mutations. So because of activating mutations, the channel or gain of function mutation, so this leads to basically the channel does not close, the channel remains open. So if the channel remains open, insulin cannot go out. And the opposite thing would happen in in congenital hyperinsulinemia, where more of insulin will go out if there is loss of function mutation. So when to suspect neonatal diabetes? This is important because specifically in newborns, we know, especially in preterms, hyperglycemia is not uncommon. So many stressors like sepsis, dehydration, hypoxia, surgery, they often lead to hyperglycemia in newborns. Why? Because of the stress hormones, so specifically cortisol, epinephrine. So these lead to hyperglycemia. We have all seen cases with hypernatremic dehydration presenting with very significant hyperglycemia. Then iatrogenic causes are again very common: high GIR, steroids, beta agonists, caffeine. So they are more common in preterm or very low birth weight infants. But hyperglycemia without known risk factors, persisting for more than 3 to 5 days, insulin dependent, then we should start workup for neonatal diabetes. Remember that IUGR is common because insulin is important for fetal growth, and up to 50% of affected babies present with diabetic ketoacidosis. So due to presence of fetal hemoglobin, HbA1c is unreliable in children below 6 months. However, HbA1c of more than 6.5% does support the diagnosis of neonatal diabetes. So let's look at the pointers to diagnosis of neonatal diabetes in various age group. If it is a newborn, so as I said, if there is persistent hyperglycemia more than 250 lasting beyond 7 days, or actually I would not particularly wait for 7 days if there is no risk factor, it's a term baby. If it's a very high blood sugar, then actually I would start investigating even earlier, or dependency on insulin to maintain euglycemia. Less than 6 months, all infants with diabetes. So beyond the neonatal age group, the child is below 6 months presenting with hyperglycemia, you have to think of neonatal diabetes. 6 to 12 months, those with negative autoimmune markers, as in the case presented by Dr. Sandeep, or with pointers, as Dr. Abhishek also mentioned, which like extrapancreatic or pancreatic exocrine insufficiency. So if the baby has these pointers, then you would look for neonatal diabetes genes. Or more than 1 year, you would still think of there are particular monogenic forms, which can present later also. So neonatal diabetes in the sibling, no insulin requirement after prolonged honeymoon phase, or again, associated features like hepatitis, neurological features, hearing defect, or anemia. So if we look at neonatal diabetes, it can be broadly classified in transient and permanent neonatal diabetes. In transient neonatal diabetes, you have 6q24 abnormality, including ZFP57 mutations, and I'll talk about it a little later in the presentation. And then you also have these mutations. So the potassium channel mutations can present as transient neonatal diabetes as well. And then HNF1B, as was mentioned in the session on MODY. So this can sometimes present with neonatal diabetes, which is transient. And then insulin gene defects, as we know, which ones? The homozygous ones. So permanent neonatal diabetes, you can have non-syndromic ones like the ABCC8 and KCNJ11 mutation, insulin gene mutation, GCK, homozygous GCK. We know GCK causes MODY when it is heterozygous, and in homozygous state, it can cause neonatal diabetes, and IPF1 gene defects. And then there are the syndromic causes where you have the transcription factor defects like PDX1, PTF1A1, GATA6, NeuroD1, then immune response defect. FOXP3 is very important, IPEX syndrome. And although I really haven't diagnosed one, although we did see one baby with probable IPEX, but baby unfortunately succumbed before we could do the testing. But there are reports from India also, including, I think there are reports from Vellore. So babies with IPEX have been diagnosed here. Then endoplasmic reticulum protein trafficking defects, in which the most important is IF2AK3, which is actually the Walcott-Rallison syndrome, which is associated with various features, including spondyloepiphyseal dysplasia, which is a very important manifestation, and liver failure. And then you have the transmembrane channel regulator defect. Again, KCNJ11 and ABCC8 can sometimes present with syndromic findings like DEND syndrome. Then you have the Roger syndrome, or thiamine-responsive megaloblastic anemia, and Fanconi-Bickel syndrome, which Fanconi-Bickel is often associated with the transient form of neonatal diabetes. And I would like to acknowledge that this particular slide I have actually taken from the chapter on neonatal diabetes, which is contributed by Dr. Hemchand, who is here today, and for our book, the second edition of our book. Okay, so coming to the case that I had first presented, if you remember, it was a baby who had presented at 1.5 months with a strong family history in the form of a sibling death and born to a third-degree consanguineous family. So in that baby, the mutation analysis, which we got done from MDRF Chennai by Dr. Radha, so we were able to identify IF2AK3 homozygous variant. So this encodes this particular enzyme called PERK, and this leads to defect in the trafficking of proinsulin from endoplasmic reticulum to the Golgi bodies. So there's a defect with insulin secretion, and also these ERs, they actually lead to a lot of stress and finally apoptosis as well. So it is a permanent neonatal diabetes. And I looked at this particular recent systematic review on IF2AK3. So this particular mutation is actually quite common in India. And of course, it is one of the commonest in Middle Eastern countries because of the high consanguinity rates. So this publication looked at 189 patients, and they found that the median age of presentation was 2.5 months. And besides neonatal diabetes, liver involvement and impaired growth was seen in about 70%, skeletal abnormalities in 60%. And there were other abnormalities like CNS, kidney, hematopoiesis in about 35%, and rarely also exocrine pancreatic insufficiency. The survival rates, when we look at the 1, 5, and 10-year survival, it was 89%, 65%, and only 53% at 10 years. And the commonest reason for mortality was actually liver failure. And this is typically episodic, and it can even be precipitated due to the stress of vaccination. So it is important that when you make a diagnosis, like we made a diagnosis in our 1.5-month-old baby, so we advised that all the vaccinations also, they should get, either they could get prophylactically hospitalized, or they have to be very, very careful. And we explained all the findings and all the symptoms that they should be very careful about. So in fact, liver transplant has been performed in 9 individuals. And in fact, now there are reports of sort of preemptive liver transplant as well. And patient survival was noted to be better in the transplant cohort and in those with the missense variants. Coming to another case, a 6-month-old girl presented with fever, cough for 5 days, loose stools, and fast breathing for 1 day. She was noted to have a hemoglobin of 2 grams per deciliter when she presented to an outside hospital, and random blood glucose was more than 500. So she was given a transfusion, then she was sent to us, and she was actually a full-term baby with a good birth weight of 3.5 kg. and first offspring of a consanguineous couple. Here again, it was a consanguineous marriage. Current weight of the baby was 5.1 kilos with a length of 63 centimeters, and she therefore had failure to thrive. She had severe decay at presentation. She was managed with the packed RBC, ketosis resolved with fluids and insulin, but hyperchloremic acidosis developed. Her insulin requirement actually went down to about less than 0.3 unit per kg per day over 3 to 4 days, although initially her requirement was about 0.8 unit per kg. After the initial transfusion, she again had a drop in hemoglobin as well as her platelet counts dropped, requiring PRBC and platelet transfusion. So this was a baby born of a consanguineous marriage, had anemia, and actually sort of cytopenias. The TLC I have not given here. Probably it was normal if I remember correctly, but she had bicytopenia. So what are we thinking of? What are the possibilities here? So one is that we should remember that sometimes, other conditions can also mimic diabetes. And so one of the conditions that we thought of in view of, acidosis, which actually sort of after ketosis resolution, also there was acidosis, insulin requirement had gone down, there was bicytopenia. We also thought of inborn error of metabolism, organic acidemia. But ammonia levels were sent in this baby and they were normal. And then we thought of thiamine-responsive megaloblastic anemia or Roger's syndrome because she had megaloblastic anemia actually. So we actually did further tests for this baby. We did a BERA and it was suggestive of severe, profound bilateral sensory neural hearing loss. So even we sent the genetic test, but it typically takes time for the report to come. So we did start her on thiamine 100 milligrams OD, and we were actually able to stop the insulin altogether, and hematological parameters also improved. And later on, genetic testing did confirm SLC 19A2 mutation, which was homozygous. So this was thiamine-responsive megaloblastic anemia. Important thing is that, it's not that you start somebody on an oral medication and then they are happy. They sometimes think that, okay, the child is cured now. So actually this baby presented about 1 month later, again with hyperglycemia, because the parent had stopped giving the baby thiamine. They thought the baby had been cured. So there are case reports where children can actually present with DKA again if they are not compliant with the medication. Also, is it like we saw a very good response to thiamine, but is it universal? So I looked up this particular, a large series where they looked at response to thiamine in TRMA, 15 children. Age of onset of diabetes was between 6 weeks to 8 years. Age at starting thiamine was 6 months to 14 years. A dose of 25 to 150 milligram per day. So 7 out of 15 showed an improvement in A1C, 4 became insulin independent. So we have also seen 3 other children previous to that, and all were older. And that is why this case came as a surprise to me also, because this baby was only 6 months old, whereas all our previous children were between 2 to 5 years of age when we diagnosed them. So, and none of them showed such a good response, but this baby showed a very good response. So remember that there may be intermittent hyperglycemia and they may stop taking. So ensure compliance. So if we look at some of the causes of syndromic neonatal diabetes, I have already covered Wolcott-Rallison. And again, Wolcott-Rallison, again, remember that the onset, the median, as we saw, was around 3 months, but it can occur even in the second year. So this is one of the causes of neonatal diabetes that can present late, a little late. We have seen children who have presented at 15 to 18 months. Then Fanconi-Bickel syndrome is another important cause, although rare. So it causes generalized proximal renal tubular dysfunction. There is transient neonatal diabetes, hepatomegaly, and rickets. And again, the course is variable. IPEX, which is X-linked polyendocrinopathy, enteropathy, immune dysregulation because of the FOXP3 gene, can present right at birth. And then we have TRMA, which I have already discussed. Again, the onset of TRMA can be between infancy to adolescence. And thrombocytopenia is common. Neurological involvement may be there. Cardiac or optic involvement can also be there in affected children. Deafness, of course, is very, very common. So coming to transient neonatal diabetes. So in transient neonatal diabetes, IUGR is common. Presentation is typically very early, first few days to weeks. So the cases of transient neonatal diabetes that I can recall from my experience, they have typically presented within the first 2 to 3 weeks. Presentation as DKA is less common though. Umbilical hernia or omphalocele may be a pointer to transient neonatal diabetes. It typically resolves within few weeks to months, may show the following course: permanent remission, hyperglycemia during illness, hyperinsulinemic hypoglycemia in infancy, and recur mimicking type 2 diabetes. So I think we already have seen the case that Dr. Greeley presented. So these are the various things that we actually have to keep in mind. So it was a very interesting case that he had presented. I have not seen such a case, but yes, this is how it can present with a transient neonatal diabetes and later mimicking type 2 diabetes. So periodic monitoring of HbA1c is mandatory after the infant has gone into remission. Typically, insulin is used in infants, and later on, if diabetes recurs, then it is typically responsive to sulfonylurea, but successful use of sulfonylurea has been reported in newborns with chromosome 6 related transient neonatal diabetes also. So the molecular defects in more than 70%, transient neonatal diabetes is caused by overexpression of the 6q24 imprinted chromosomal region. So this is the normal chromosome 6 long arm where you have two genes, PLAG-L1 and HYMAE, which are expressed from the paternal allele, but they are imprinted in the maternal allele. So they're not expressed. Now, if they're overexpressed, what could be the mechanisms of overexpression? One is that the father there can be a unique parental disomy from the father, both the chromosomes, both the alleles coming from the father, or it can be that there is loss of maternal methylation. And both of these particular things, paternal UPD and loss of maternal methylation, these are very, very sporadic events, de novo sporadic events, they won't recur. But the third mechanism is paternal duplication. So there is already a duplication on one of the alleles of the father. So this will actually present like an autosomal dominant kind of presentation, and you can have recurrence in subsequent pregnancies. Another important gene is ZFP57, and we have seen one case here again in a consanguineous family with one previous sibling affected, and so they actually brought the second sibling very early. So ZFP57 actually codes for transcription factor, which is required for methylation of several genes. So if there is a mutation in this, then there is loss of methylation for several genes, and this is the mechanism how it causes TNDM. And in up to 25%, there can be other genes, which we have already alluded to. So permanent neonatal diabetes requires lifelong therapy. Median age presentation is 3 to 8 weeks. Mean birth weight is 10th to 25th centile. So it's generally a little higher than that seen in transient neonatal diabetes. Approximately 40% of PNDM are caused by potassium gene mutations and are amenable to sulfonylureas. The rest actually need permanent insulin treatment. And DEND is an uncommon, but yeah, maybe I have not seen that many, but yes, because we know that these same potassium channels are expressed in the neurons also. So some of the children can be present with varying neurological manifestations ranging from frank epilepsy and developmental delay to mild neuropsychological manifestations. So coming to one more case, a 1-month-old female baby born at term to a non-consanguineous couple with an antenatal history of oligohydramnios with IUGR with a low birth weight presented to a hospital at Ranchi. So at 1 month old with fever, fast breathing and polyuria. She was diagnosed as DKA and started on insulin, and she was on exclusive breastfeeding. And then she was referred to us in view of uncontrolled blood sugars. So she was admitted with us at 2 months. Her she was low birth weight, and current weight was also low. HbA1c was high. Other investigations were normal. DNA was sent for genetic diagnosis, and we actually found a heterozygous KCNJ11 missense mutation. And she was started on sulfonylurea, and dose was increased to maximum of 1 mg per kg per day, and we were able to stop insulin on day 7. So here I included this case particularly for the CGM record. So this was the CGM record while the baby was on insulin. And it shows how difficult it is to actually maintain babies on NPH and regular. And unfortunately, in a government setup, hardly any of our patients can actually afford a pump. So this is how we manage typically on glargine and short-acting analogs. But this case was older. This is actually a 12-year-old case that I'm sharing today, just because of the CGM record. So here you can see that the sugars are all over the place, and euglycemic are actually only 12% of the records. And then after switch over to sulfonylurea, 83% of the records are euglycemic, and you see what a nice curve we get. So this is how sulfonylureas actually, just change the management. So what about sulfonylurea without genetic diagnosis? So another baby, this baby actually we saw very recently, second born baby to a non-consanguineous couple, and presented to a hospital at another city at 4 months with the short duration of polyuria, fast breathing. He was diagnosed as moderate decay, started on insulin. And when he came to us at 5 months, the main complaint was that in the past 1 month, he had had multiple episodes of seizures. Query due to hypos, but the parents didn't know about it. They said, we are not very sure. Maybe a few were due to hypos, but there were seizures otherwise also. And he had complete regression of milestones. He was not even able to hold his head. So we managed initially on Glargine and Humalog, but the control was erratic, although the total daily dose was only 2 to 3 units. Actually, our residents thought that it would be good to start on glibenclamide because this looks like possible dent. So we started on glibenclamide. Dose was increased to 0.8 mg per kg per day and were able to stop insulin on the 4th day of starting glibenclamide. But what happened later? After 2 weeks of discharge, actually blood sugar readings again started increasing. And we got the report another week later, and it was a heterozygous INS gene mutation. Actually, then it became very, very difficult. Even with readings of 300 plus, the parents were totally refractory. It really took a lot of convincing for them. Initially, they just started with Glargine, then very, very reluctantly, they and continued to give glibenclamide despite our telling them not to give. So it becomes difficult. So after this case, I think my advice would be to actually wait and not start without a clear diagnosis. So I think this we have already discussed that basically whenever you see, you have to take a detailed history, including consanguinity, gestational diabetes, because it could be GCK in the mother and then biallelic GCK in the baby. Evaluation of first degree relatives by OGTT will also help you in giving some clues. And then look for extra pancreatic features. Do an ultrasonography for pancreatic agenesis, renal abnormalities, structural abnormalities in the brain. You can think of doing brain imaging if required. Genetic testing in all below 6 months and in more than 6 months if autoantibodies are negative. So this slide is again courtesy the chapter by Dr. Hemchand Prasad in our book, Case-Based Reviews. So again, this summarizes all the extra pancreatic features that you can see. And for lack of time, I'll not go into too many details, but let's move on to the next case. We'll continue with the management. So clinical presentation can give clue to the underlying defect. DKA is found in more than 75% of patients with mutations of KCNJ11 and ABCC8, but not seen in those with transient neonatal diabetes. Malabsorptive diarrhea can give you a clue about these particular genes, and then extra pancreatic features can suggest which particular gene may be involved. So the current algorithm is that you do a early non-selective NGS for all known NDN genes, and because some of the clinical features may evolve. For example, we know that the spondyloepiphyseal dysplasia will not present in the early infancy. The manifestations will develop on later once the baby is older, between 18 months to 2.5 years. So once you've done the testing, then you can actually be vigilant for other conditions. So management, typically DKA is managed as per usual protocol. Start with a low dose of insulin. Be especially vigilant for HHS and cerebral edema. The dose of insulin, once they shifted to subcute insulin, the dose is quite low. Ideally, as discussed earlier, CSII is best, but not always affordable. So if using injections, may need to dilute insulin. Again, low subcutaneous fat is there in babies. So it is a challenge to actually give insulin subcute 3 to 4 times a day. Erratic feeding is a challenge. Avoiding hypoglycemia is important. Targeting sugars between 100 to 200 may be preferable. And they should be given very clear written instructions about dose, managing hypos. Close follow-up has to be maintained. Trial of sulfonylureas without a molecular diagnosis, probably not a good idea. Sulfonylureas are effective in more than 90% of those with activating mutations in KCNJ11 or ABCC8. And the dose has been already discussed. I think we can leave it. So comorbidities have to be managed effectively. And just coming to a further experience from India, I'll just club our experience. We had published one case series with 11 babies of which 8 had permanent neonatal diabetes. This we published in 2017. After that, we've had 12 more patients. And so out of 23 infants that we have managed with neonatal diabetes, only 4 had variations that were amenable to treatment with sulfonylurea. So it's not really that it is the commonest cause. I think in India, it's KCNJ11 and ABCC8 may not be the commonest cause. I've tried to summarize other reports from India. And some have, like in the publication from Chennai MDRF group, they see from all over the country. So they did see a significant number, but many others did not see. And this is a summary of about 65 cases with permanent neonatal diabetes reported by various authors from India in case series. And if you look here, ABCC8 and KCNG11 together make about 41% of all cases. And rest are actually not amenable to sulfonylurea. So I'll finish with the key messages. So diabetes presenting before 6 months of age is most often monogenic, and in older children, if there are syndromic features or other or the antibodies are negative, then you look for these genes. Right, roughly 40% of the PNDM cases are caused by potassium channel defects. Among syndromic causes, Wolcott-Rallison syndrome is the commonest. Genetic testing should be done in all to guide the management and prognosis, and management is challenging, requires close hand holding, and even in children on OHA and thiamine, ensuring compliance and continued follow-up is important. So I'll finish with my thank you slide, and this is showing the second edition, which was released last year. So students can possibly look at it. Thank you.
Thank you. Thank you, Professor Jain, for that excellent presentation. And a question and a couple of comments for you. Your patient with homozygous ZFP57 mutations, did you see the typical features like umbilical hernia or anemia, hypothyroidism with a gland in situ that we would see in a 6q24 anomaly? Because the 6q24 is typically due to overexpression of the plagal ZAC or HYMA, whereas here you are dealing with a regulator ZFP57. So were the clinical features different or were they similar?
That particular baby had IUGR, and it was very interesting that that baby actually presented at 1 week of age, and the parents were themselves monitoring because they had a previous baby who died because of neonatal diabetes because it was diagnosed late. So they were from Bihar, and this particular baby actually in follow-up itself, before we even got the genetic report, the baby had gone into remission within, I think, 2-3 months. And the baby, as far as I remember, very clearly, the baby was low birth weight, probably around 1.5, 1.6 kilos. Apart from that, the baby actually looked okay. And I think the thyroid function was also normal. So we were actually when we got this report of ZFP57, we actually did not understand because we were thinking, okay, it should be 6q24. Then we read up about it, and this is how we, but yeah, did not have other features.
So, I mean, while it's like widespread hypomethylation, which also involves the 6q24, but some of them may not show the typical features that are seen in the overexpression of ZAC plagal. And 2 quick comments with the GCK, one of the commonest causes of MODY, which usually doesn't require treatment other than pregnancy, whereas homozygous one present due to complete lack of glycolysis. And parents generally here do have hyperglycemia. So the homozygous ones, typically the catch is parents are, they have hyperglycemia, never requiring treatment.
Yes.
INS, strangely, in our experience, I mean, we have a series of now 17 neonatal diabetes. We are in a process of writing it. By the year, we'll probably complete. Is while the heterozygous ones are permanently insulin dependent, homozygous INS do remit. I mean, and we read a lot of literature when we were managing, and we found that homozygous INS ones do remit, and that's strange. And Zalak, to your question, dilution of insulin, up to 0.5 units, you may not need to dilute, but lesser than 0.5 units if you're not administering via the pump. At pump, you can obviously, with a pump, you can administer 0.1. You can dilute with normal saline, 1 in 10, or then a bona fide insulin diluent, which is available with difficulty. It's called the bona fide insulin diluent, and 1:10 dilution again there. But Usually normal saline, the easiest.
Yeah.
One
We have used normal saline only. This insulin diluent, we were not able to get
yeah.
for any of our
Very, very
babies. Yeah.
difficult to procure, but 1:10 normal saline.
But you really have to explain to the family very clearly how to dilute because it's
Yeah.
not easy. And but once the parents understand, then they are able to manage. Yeah.
So in practical experience, it's easier to use the pump in the hospital setting rather than diluting insulin.
We have a question in Q&A section, sir.
Yeah, we'll take Madam
It's
Jain.
answered. Yeah, it's answered by Dr. Siri.
Yeah.
Okay.
I could review that, but it's just that the question was about Modi versus neonatal, and it really just has to do with how strongly activating the variant is. So the ones that are less strongly activating can be transient, and those are the same variants that can also present as Modi. So within the family, you might have some where a parent or a grandparent had Modi, and maybe you didn't even know about any neonatal phase in that case, because it was relatively mild and it was never picked up. Whereas you might have a baby in front of you where you don't even know yet if it's going to be transient. But if you have an interesting family history, that would be another reason to really consider the genetic testing. But there isn't too much of a mechanistic difference between the Modi and the neonatal, but it's more about how strong it is. Of course, those genes can get really complicated when you start talking about hyperinsulinism and everything. And we're actually, as part of our gene and variant review panel, we're trying to go through a lot of that, and it can get pretty complicated. I wanted to just a quick question with the saline dilution. How often do you have them dilute it? Because when we do that, sometimes in our hospital, we do it like on sometimes a dose by dose or at least a day by day basis.
We do it on a day by day basis.
Okay, because that's the best thing about the diluent is that it's stable for 30 days, like any vial or pen. And I
It's
guess
not
we're lucky.
available in India actually,
Yeah,
so
that's
that's an issue.
unfortunate.
Yeah.
Has anyone tried to reach out to the manufacturers? Because it's really just that's how it's provided to us is by Lilly or Novo. But whichever manufacturers in India, they could provide it to you, and they do it for free as a courtesy to the providers in the US, and that's really unfortunate that
Actually, even half unit pens are not easily available. We only have it for Humalog. We don't have it for Novorapid, and for Humalog also sometimes it's difficult to arrange the half unit pen. So it's as an issue. Dr. Siri, also, if I may just quickly add, we had one baby who had CHI due to ABCC8 compound heterozygous mutations, and this baby was like managed medically, and she was doing well on octreotide, and later on we shifted her to LAR, and now she's about 12 years of age, and now she's actually the requirement for LAR actually went down significantly, and now she has started having high readings, intermittent hyperglycemia, and HbA1c is 6.9. So again, this kind of conversion of the same mutation from sort of inactivating to activating, how does that occur? It's very interesting.
Yeah, that gets pretty controversial, and that's exactly one of the topics we're trying to tackle in the group. And we have people like Colin Nichols from WashU and Fran Ashcroft and others who know those channels really well. It's not entirely clear, but the kind of simplistic way of thinking about it is if you have overproduction of insulin over many years, there's this idea of like burnout of the beta cells that begin failing later on and might predispose those individuals to diabetes later in life. But it's the main important thing to understand there is that the mechanism is now completely different than the variants that cause neonatal or MODY. And so sulfonylurea in particular is really the wrong choice for those patients because their beta cells are already burned out, and that's really the problem.
Yeah.
So if you push the beta cells further, it's not useful. And so people like Charlie Stanley at CHOP have long recommended using metformin, for example, to just take the load off the cells, and that might work for a time. But then the other things that may be useful in older people, I mean, teenagers or older, you could think about SGLTs, medications if you have them, or GLP-1s for sure if they have, especially if they have obesity. But to think of it probably more like type 2 in those cases and to avoid sulfonylureas. I did one other thing with your case with the insulin gene variant was I just have to say that's very unusual. A couple aspects. One is having the seizures. We don't usually see in those cases unless the diabetes presentation was so severe that we think with the extreme dehydration they may have had like a stroke or some other like brain injury that predisposes them now to seizures. And I agree that when you go into that idea of treatment with sulfonylureas before a genetic diagnosis, you have to be really careful about it. We have a paper about it, which I know Andrew Hattersley is worried that we're kind of opening a door to difficult situations. And we tried to be careful with that paper to point out that if you're going to try the trial, it's so important to still get the genetic testing. And the other thing I can't emphasize enough when I talk to people about it is when you talk to the families to really be clear about their expectations and understand that it really could fail, or it may not work long or whatever, and you might have to come off of it. And that is unfortunate that you ended up in that situation. And that is the kind of thing we worry about. And I've actually mentioned insulin genes as a possible way where you might think there's a response to the sulfonylurea initially because there's some beta cell function left, and then it won't last, and you could theoretically even maybe make the beta cell death occur a little faster. And so that's interesting that you had a case like that because that is something I have worried about. It's a
Yes,
cautionary
and
tale.
possibly
Yeah.
the seizures and the loss of milestones were probably related to like poor monitoring of sugars because he was initially admitted at some other place and then he was at home for some time.
Yeah.
Probably
I
they were
wonder
not
about
monitoring
that.
well, so it may be all related to that. And later on, yeah, it was actually difficult, very difficult for us to convince them to, start insulin properly. They were like still hoping, no, it will work, it will work. And yeah.
Yeah.
If we don't have any more questions, we'll hand over the session to Anurag sir then. Over to you, Anurag sir, for your concluding remarks.
Thanks a lot, Abhishek, for the wonderful input that you've given. And once again, I have to thank Dr. Siri Atma Gilli and Professor Vandana Jain for providing wonderful insights on both neonatal and monogenic, one part of diabetes which has been often neglected in that perspective. Special thanks to Dr. Hemchand and Dr. Abhishek for making such interesting discussion with regards to both forms of diabetes, as well as to Dr. Aarti and Dr. Sandeep for these wonderful case presentations. Dr. Jhalak, who has done a wonderful job over the last so many years with this regards. And we will continue with these sessions. And once again, thanks all of you for joining and discussing on that. Over to Dr. Jhalak for the final conclusion.
Thank you so much, sir. Thank you, Anurag sir, for coming up with the wonderful, interesting, very interesting topic of monogenic diabetes and wonderful speakers today. Thank you to our speakers and experts, Dr. Siri, for joining all the way from Chicago on Saturday morning. We appreciate it. It's an honor to have you. Thank you, Professor Vandana Jain, for the very excellent presentation on neonatal diabetes, a case-based approach. We appreciate your contribution to neonatal diabetes. It's a privilege to have you. Thank you to our mentors, Dr. Hemchand Prasad and Dr. Abhishek Kulkarni, for leading the discussion so well. Rapid fire questions were very good. Dr. Aarti answered them very well. Thank you to our case presenters, Dr. Sandeep and Dr. Aarti. You did a wonderful job. Congratulations. Thank you to all the delegates for joining us today. Thank you, RX event, for conducting it very smoothly. And the next ISPAE ACES will be conducted on 21st June, Saturday, 7 p.m. to 9 p.m. We'll be soon coming up with the topic. Thank you everyone for joining. Good night.
Thank you. Thank you, Dr. Jhalak. Thank you, Dr. Anurag.
Thank you very
Can
much.
we have a photo before we leave? Everyone, please smile. Dr. Sandeep and Dr. Aarti, put on your video, please. Yes. Thank you. Thank you.
Thank you very much. Good night.
Good night.
All the best, everybody. Good night.